get started, I want to welcome you and appreciate you coming today for our esteemed Huntley Lectureship in honor of Dr. Robert Huntley. I'm Dr. Christy Page. I think I know most people here. We have residents and fellows and faculty, friends and alumni of UNC Family Medicine. I'm the chair of Family Medicine. I'd like to reflect a moment on our values. In everything we do, we're working to create a more compassionate, effective, cost-efficient, and patient-centered healthcare system, an actual system in the future. That's also rewarding for health providers to work in. A system that works for rich and poor and all of those in between, a system for those in urban and rural communities, a system that properly uses the talents and the skills and training of all types of physicians and health workers, and a system ultimately that enables all people to live longer, healthier lives. So this lecture is important to that mission. Over 14 years ago, Dr. Joan Huntley, along with Dr. Warren Newton, saw the need to bring new ideas to UNC and to share our ideas with others. They developed together the Robert R. Huntley Visiting Professorship and Lecture in memory of a great physician leader, Dr. Bob Huntley. It was made possible by the vision and the philanthropic support of an equally great researcher, leader, and friend, Dr. Joan Huntley, who's sitting with us today. And let me take a moment to say how much I've appreciated over the years getting to know Joan, who was a pioneer academician in epidemiology, someone who inspires me personally to make an impact as a woman leader. There's no doubt that our visiting professors have impacted us as well. Today we'll expose factors related to disparities in healthcare and push ourselves to do more to address those factors. We'll learn about the social determinants of health, implicit bias, true disparities in our own state, and consider how to move toward equality of healthcare of the highest quality. I also want to acknowledge that UNC Family Medicine and our partners, many in this room, are collaborating to try to make a difference and try to ameliorate health disparities. With some examples of a FIT program, Dr. Ed Ashton is here, which connects formerly incarcerated individuals who have a chronic disease with a primary care provider and a comprehensive reentry plan. We have an underserved residency training track in Tazewell County and are soon expanding that to Chatham County as a major initiative to use the educational innovation and clinical innovation to provide access to care in rural counties and to provide a pipeline for family physicians in rural areas. We have ACA enroll-a-thons to help people get insurance. We have a whole host of community initiatives to try to make a difference. And each of these programs, among others, focused on improving clinical care, research, and education, are made possible by private giving like Dr. Huntley's. So it is the passion and the generosity of you in this room that allows us to innovate, to train, and to pursue opportunities that impact the health of North Carolinians and around the world. To everyone here who's been a part of supporting that work through your giving, we are deeply grateful for you, and we need you to continue that giving in order for us to expand our impact. And while we're passionate about addressing health disparities and making a difference in the world, we have no illusions that we have any of this figured out, which is why we invited Dr. Denise Rodgers to come and talk with us and enlighten us and to help us move forward in making a difference. So I get to introduce her now. Dr. Rodgers received her medical degree at Michigan State University, completed her family medicine training at Montefiore in the Bronx in New York. She's currently Vice Chancellor for Interprofessional Education at Rutgers, Biomedical and Health Sciences. She's the Hunterdon Chair in Interprofessional Education at Rutgers-Robert Medical School and Professor in the Department of Family and Community Health. She has many accolades, and she asked me not to go carry on about the whole life story. But I can tell you that in her time here already, she has inspired us and challenged us. And personally, as I think about what do I want to be when I grow up, I look to a role model like Dr. Rodgers for the kind of passion and values that she brings, and the impact that she's having to make the world a better place. And with that, I introduce Denise Rodgers.
Thank you, Christy, for that very kind introduction. I just want to make sure that people in the back of the room hear me sufficiently before I get started. Yeah? Good, thank you. I'm also going to turn on my phone here so that I can time this to try to not run over too long. Let me also disabuse you of any notion that I have figured this out. And so I am here for all of us to learn together and speak together and continue our efforts to make things better for the patients that we care for. Nice day, easy for you to say, but not for you. No, my kind is dying off. Man, my peer group's sure getting hammered lately. What peer group is that? Middle-aged whites, the mortality rate soaring. They're called deaths of despair, from drugs, alcohol, or suicide, driven by economic and social distress. Oddly, it doesn't seem to affect blacks or Latinos. Nothing odd about it, man. We've always lived distressed lives. We're used to it. So, black privilege? Absolutely. We're lucky that way. So this is the study from The Lancet that demonstrated that between 1999 and 2014, premature mortality increased in white individuals. And among 30-year-olds, annual mortality increases were 2.3% for white women and 0.6% for white men. It also showed that these increases were mainly attributable to accidental deaths, primarily drug poisoning, chronic liver disease and cirrhosis, and suicide. Among individuals aged 25 to 49 years, an estimated 111,000 excess premature deaths occurred in white individuals. If we look at data from your state, we see that you face these same challenges in terms of death from suicide, of death related to opioid overdoses. We have a significant problem as well with American Indian populations from opioid deaths as well. That's the part of the study that I just went over with you that most people paid attention to. The other thing this study said, though, was that between 1999 and 2014, premature mortality increased in American Indians and Alaska Natives, 4.3% and 1.9% for American Indian men and women. I'm sorry, women and men, respectively. Same issues, in white population, and 6,600 American Indians died prematurely from 2000 to 2014. During 2011 and 2014, American Indians and Alaska Natives had the highest premature mortality. And that didn't make any newspaper articles that I could find. And they were followed by African Americans, who continued, despite rising premature mortality in whites, continue to have the second highest premature mortality in the United States. We've been talking about premature mortality now for well over 30 years, and it really started systematically looking at these issues under President Ronald Reagan with the report of the Secretary's Task Force on Black and Minority Health. This report found 6 causes of excess mortality in blacks and other white minorities. As folks will know then, they were cancer, heart disease and stroke, chemical dependency, diabetes, homicide, suicide, and accident, which all sort of lumped together at that time, and infant mortality. However, very soon after the report was issued, a 7th cause of excess mortality was added to the list, HIV/AIDS. So I'm going to go through a series of slides fairly quickly. Don't get frustrated that you can't read the numbers, because I'm not interested in you reading numbers. I'm interested in you looking at the proportionality here. And besides, for those of you in the back, the numbers may be a little difficult to see at front. But if we In North Carolina, at cancer mortality, we see disparity in cancer mortality by race and ethnicity here. We do see, interestingly and not surprisingly in this state, that Native Americans and whites are more likely to die from lung cancer related to the increased smoking rates that we see in those populations. And actually, whites have higher smoking rates throughout the country compared to African Americans. African Americans have higher death rates from colon cancer, from breast cancer, from prostate cancer. African Americans and Native Americans in North Carolina have significantly higher rates from heart disease deaths, significantly higher stroke mortality. Again, American Indians and African Americans have higher death rates from diabetes in the state. And American Indians in particular have significantly higher rates of deaths from chronic liver disease and cirrhosis, undoubtedly related to significantly higher rates of alcohol use. Chronic lower respiratory disease is higher again in whites and American Indians, in part related to higher smoking rates. When we look at homicide mortality, North Carolina is one of the few states in the country where African Americans actually don't have the highest homicide rates. Those rates are exceeded proportionally by Native Americans in this state. But in both instances, you'll see these death rates are significantly higher in these populations than they are in the white and Hispanic populations in this state. Like the rest of the country, infant mortality, black infant mortality in North Carolina is 2.5 times greater than white infant mortality. In my state of New Jersey, the disparity is 3 times. Just look at this slide for a moment. And this is what your disparity in HIV mortality looks like here in North Carolina. So this is what black privilege looks like. Summary of what black privilege looks like. And so 30 years after the Secretary's task force report, we still see that we have done not nearly enough to close the gap in disparities in health outcomes by race and ethnicity. I want to remind you, as I reminded myself in doing this presentation, that this is what the demographics of our state look like. And so one of the things that really jumped out at me in looking at North Carolina is that 1.2% of your population is American Indian, and this is a very, very sick, very distressed population. I don't know how much you care for this population, but certainly if you're proximate to being able to care for this population, they need incredible interventions and extra work, if you will. So what are social determinants of health? The World Health Organization tells us that social determinants of health are the circumstances in which people are born, grow, live, work, play, get old. There are also the systems in place to deal with illness, and these circumstances are in turn shaped by a wider set of forces, economics, policy, and of course politics. If we look at this chart that comes from County Health Rankings, which is out of the University of Wisconsin, funded by the Robert Wood Johnson Foundation, we begin to understand that of all the health factors that contribute to health outcomes, social determinants of health contribute 40% of the health factors that ultimately lead to outcomes. We should be humbled as we realize that what most of us in this room do contributes only 20% to people's health outcomes. People's own behaviors contribute 30%, and the physical environment contributes another 10%. So let's start looking at some social determinants both here and in the country as a whole. Let's start looking at median income. You see that in 2016, Asian Americans earned the highest household incomes at well over $80,000, and African Americans earned the lowest household incomes. In the state of North Carolina, we see that whites have the highest household incomes and African Americans have the lowest household incomes here as well. If we look again at the country as a whole, in the years between 1963 and 2016, we see that basically the poorest of the poor in this country during that period of time have had relatively little increase in their incomes. And the richest of the rich have become even richer. And that's what that yellow line represents. So people in the middle, sort of okay, but certainly nowhere near what the richest of the rich are. If we look at data about the poorest of the poor by race ethnicity between the years of 2011, 2012, and 2013, we see that African Americans and Hispanics in that category of the poorest of the poor, the lowest 10th percentile, had no income whatsoever, compared to about $10,000 for whites and about $15,000 for Asians. Let's look at wealth. So if we look at wealth of the bottom 10th percentile compared to the top 1 percentile, in 1963, the bottom 10th percentile were about $19 in debt, and the richest of the rich had about $1.4 million of accumulated wealth. By 1998, the good news for the poorest of the poor, the 10th percentile, is they had no debt. And the top 1% had assets of about $5.6 million. When we fast forward to 2016, it becomes realized that the poor are about $950 in debt, and the richest of the rich are now worth about $10.4 million. If we look at family wealth by race, we see that these gains in wealth have been disproportionately aggregated in the white population, with African Americans and Latinos making some modest gains, but clearly nothing close to the scope seen in whites. If we look at the factors that contribute to wealth, the top factor is home ownership. Income, obviously, is a major factor. Unemployment or having a job, obviously, plays a major role. Education, financial support, inheritance. So if you start out rich, then you're likely to stay rich and accumulate more wealth and get even richer. And then, obviously, that relates to your starting debt. So let's look at home ownership by race in America. And what we see is that whites, about 70% of whites have owned their own homes from this period to 1976 rather, to 2016, without much variation, and just under 50% of African Americans and Latinos. And so what we also see is this notion of the promise of America, where people will do better over time, has not played out for so many in this country. So what does all this mean about health? This is about morbidity, not mortality. This tells us that people living in households that earn less than $45,000 are more likely to have all of these things by that percentage. So track with me here. If we look at the population of the bottom 10% of male wage earners who were born in 1920, and we compare them to the life expectancy for the top 10% of male wage earners born in 1920, we see that there's about a 6-year gap in life expectancy, right? So the poorest of the poor live about 6 years less than the richest of the rich in that cohort of people, of men, born in 1920. However, when we fast forward that to people born in 1950, what we find is the gap now increases to nearly 14 years, and if you do the math on some notion of fate here, life expectancy for the poorest of the poor increased by about 0.8 of a year, and it increased by 8 years for the richest of the rich. Here in North Carolina, this is a chart that's put out by Virginia Commonwealth University, where they compare life expectancy amongst different variables in the state for a number of states and cities in the country. And they found that along one of your highways, I think it's 64, you see that Wake County, which is pretty close to here, the average life expectancy is 80. And if you go down the road to Martin County, the average life expectancy is 73. Wake County ranks #1 in the county health rankings in terms of health outcomes for people in the state of North Carolina, and Martin County ranks number 85 of 100. 15% of children in Wake County live in poverty, and 1 in 3 children in Martin County live in poverty. Let's look at education. What we see is that if you do not graduate from high school, you are significantly more likely to die at younger ages than just graduating from high school. And then, of course, it gets even better the more education you get. So men without a high school diploma live on average 9 years less than men who have graduated with a bachelor's degree. For women, the gap is 8 years. Let's talk now for a moment about children. If we look at the top 10 OECD nations by child poverty, and I love the way they framed this slide, because this is the worst 10 OECD nations. So there are 31 OECD nations. 21 of them are doing significantly better than these bad 10. And we, of course, find ourselves as 4 from the top in child poverty. In other words, we're really bad. So this is where we are compared to the worst of the OECD nations. Nearly half of all SNAP food stamps participants in this country are children. If we look at the percentage of children in the United States by race and ethnicity, we see that not only are African American children more likely to be poor, but African American children are more likely to be the poorest of the poor. In 2013, for the first time, the actual number of poor black children in America exceeded the absolute number of poor white children in America. We need to understand that 25% of our children live in poverty. 1 in 4. We are the richest country in the world, and 1 in 4 of our children live in poverty. The American Academy of Pediatrics in 2016 published a series of articles about the adverse effects of poverty in children. I will send you these references because all of you need to read these articles. They are very powerful and compelling articles. And what do they tell us? That poverty has direct negative effects on early brain development through the mechanism of toxic stress. The epigenetic, anatomic, and neuroendocrine disruption related to chronic toxic stress may impair learning, behavior, and interpersonal relationships. This is physiological. The combination of impaired self-regulation and chronic stress may lead to maladaptive behaviors such as smoking, excessive alcohol intake, overeating, promiscuity, and substance abuse that transiently turn off the stress response. We do these things to feel better. And of course, over the course of a lifetime, contribute to higher morbidity and mortality. Children from the lowest socioeconomic stratum have a death rate from unintentional injuries that are 5 times higher than that of children from higher socioeconomic strata. Within families, poverty is associated with intimate partner violence, maternal depression, single-parent families, and parental substance abuse, all of which are risk factors for child maltreatment. And of course, it's cyclical, because many of these parents are subjected to maltreatment as well. We go back to Lyndon Johnson. He said in 1964, "This administration here and now declares unconditional war on poverty." I don't think any of us can sit here today thinking we've come anywhere close to winning that war. 4 years later, Martin Luther King Jr. in 1968 said, "There is nothing new about poverty. What is new is that we now have the techniques and the resources to get rid of poverty. The real question is whether we have the will, and the real answer today is clearly we do not." The past president of the American Academy of Pediatrics, in that article that I just talked about, said 50 years ago the U.S. came together and nearly eliminated poverty in the elderly. It's time to do the same for children. We are family physicians. It is time to do the same for everyone. You cannot eliminate poverty in children without eliminating poverty in the adults who care for them and in the adults who make up the communities in which they live and grow. We must be willing to risk talking beyond just taking care of children. We need to care about everyone. If you look at what we spend in this country compared to other OECD nations, what you see is that most of our money goes into healthcare, less of our money goes into social services, and we probably need to reverse that if we're really going to begin to make a significant difference in the outcomes of the people that we care about. Because that child who is poor in America today is very likely to remain poor in America until she dies. So I want to talk a little bit about understanding the role of unconscious bias and racism, and I want to tell you how I. So I'm showing you the homicide data, but now I want to show you the U.S. homicide data, because that's the data. This is the data that I mostly show, and in states like New Jersey, my own state, and New York, and much of the Northeast, this is what the homicide data looks like. And so I cavalierly show this data in the context of all of the other slides that I show you related to disparity in death from heart disease and diabetes and the like. And then I go on to show this data, that African American men in the United States have a 1 in 3 lifetime chance of ending up in prison. And one day, it started to occur to me that I was feeding into a racist narrative. Because if I show you all of this homicide, and then I show you imprisonment, then you say, well, of course they're in prison. Look, they're killing each other. Right? It's on that day that I decided that for me personally, that I will never, ever again talk about health disparities without talking about racism. Because if I do that, I forget to talk about this. I forget to talk about the school to prison pipeline. I forget to talk about the disproportionate number of African American boys that get suspended from school for bad behavior. And what study after study after study has shown us is that when those same behaviors are exhibited by young white boys, they get counseled, the parents get brought in, they get told, go see somebody, but they don't get suspended from school. And we know that these two groups of kids engage in many of the same behaviors. If we look at male juveniles in residential custody, because what happens after you get suspended over a certain amount of time? You're hanging out on the street, you start getting in trouble, so you end up going to juvie. Right? And if you think juvie is not 2 steps away from prison, think again. If we look at academic achievement, we see that Black children are performing less well in reading and math than their white counterparts from 4th grade all the way through. And we kind of want to say and pretend that that's the failure of families, and quite frankly, it is our failure to not be able to adequately educate these children. And in part, all we need to do is look at the disparate access to the full range of math and science courses. And part of the reason that we don't have that full range is because of these highly segregated schools that children of color attend in this country. The majority of Black and Hispanic children in the United States attend schools that are majority minority. What we also know is that these children who attend schools that are 90+% segregated have increased rates of associated poverty. So the schools that are 90% segregated are also 90% poor. What we also know when we look at the data is that poor white children are more likely to go to economically integrated schools throughout the United States. By the way, what we also know is the one most important intervention that makes a difference in the achievement gap between Black children in schools and white children in schools is integration. And we're going in the opposite direction in this country by the day, by the minute. Let's talk a moment about unconscious bias. We all have shortcuts. And these shortcuts have us make assumptions about who people are based on what they look like. I get told all the time, because of the way I dress and the way I walk, people come up to me all the time and say, you must be a school teacher. And I think to myself, I gotta change my look here. I'm kind of stern, you know? Like, I need to like loosen up or something. Unconscious bias is what makes us, when that young Black man gets on the elevator with us, hold our purses a little tighter. When that Muslim couple gets on the plane with us, it makes us think, oh my God, I hope nothing bad is going to happen. Unconscious bias still, to this day, makes us too often think that when the woman walks in the room, that's the nurse, and when the man walks in, that's the doctor. Despite the enormous gains that we have made in changing that paradigm in both directions, right? But unconscious bias drives our behaviors, and the problem with them is it does it unconsciously. But the good news is we can make it more conscious. When I talk about racism, I'm talking about prejudice plus power. The truth of the matter is, if you don't like me and you can't do anything bad to me, I don't care that you don't like me. The problem is when you don't like me and you can keep me from getting a job, keep me from getting a good education, and keep me from riding on the front of the bus and all that stuff, then I got problems, right? This is what racism looks like. And this is what racism looks like. And if we don't believe that the level of racism that exists in this country is not burned into the very marrow of our being. We are naive about the history of how this country came into being and how it came to be what it is. That child probably 50 years ago was talking about wanting to keep our schools white, and we have managed to continue to do that, despite efforts at the state and federal level to change that reality. Again, Lyndon Johnson said, until justice is blind to color, until education is unaware of race, until opportunity is unconcerned with the color of men's skins, emancipation will be a proclamation but not a fact. It is distressing to me how much the words of 50 years ago resonate today. But we've made progress. We've made some progress in part because of enormously brave people like the parents of Ruby Bridges, who allowed that 5-year-old to integrate the school. But I had another epiphany recently. I gotta tell you, my epiphanies are coming so late in life. I've been looking at this picture for decades. And only recently did it occur to me, what would it have meant for one of those marshals to hold her hand? It never occurred to those marshals to hold her hand. Because it didn't occur to those marshals to look at Ruby Bridges as if she was their own child. And that is the challenge that we face in this country. Part of that continued challenge is segregation, particularly segregation in housing. We have a very long legacy of segregation in housing. We have all of these variables that contributed to concentrated Black inner city poverty. I think somewhere there's a narrative in this country that said Black people woke up one day and said, oh, let's all gather together and live in the poorest, least well-resourced parts of town and claim it as our own. Evan told me the other night about the highway going through Durham. It's those decisions. And look at interstates all over the country. It's those decisions that contributed to concentrated Black inner city poverty. And if you want to really read about it and understand it in its fullest context, read The Color of Law and understand about how federal redlining policies and banking policies on who gets loans to live where contributes to what we see today. In The Lancet, April last year, there's a series of 5 articles on equity and equality in health in America. It's somewhat ironic that it picks up British journals and publishers. All of the authors are American, by the way, but they've got to get published. So in this article, Structural Racism and Health Inequalities in the United States, Evidence and Interventions, we learn that residential segregation is associated with adverse birth outcomes, increased exposure to air pollutants, decreased longevity, increased risk of chronic disease, and increased rates of homicide and other crimes. Residential segregation also systematically shapes healthcare access, utilization, and quality at the neighborhood, healthcare system, provider, and individual levels. Imagine what we could do if we just got rid of both racially and economically segregated housing. For many of us, we can barely remember that this dream happened. But it did. I have to tell you, I was one of these people that when he ran for president, I said they will never elect a Black man president of the United States. But we did. And then we got into this illusion that we thought we'd come to a post-racial America. And of course, we haven't. This is what we began to see come up on social media about our Black president when they decided that they didn't want Obamacare to go forward. Is there any more racially charged image than the lynching of a black man to make your point? Perhaps there is. Because this is the other image that was distributed on social media to help us not want to move forward with Obamacare. And imagine for a moment that you're the recipient of these images, right? And you're getting this message that Obamacare is coming soon to a clinic near you. No wonder so many people were afraid. Because we can click into that racist imagery that clicks into our basest fears that then has us react in the ways that those in power wanted us to. If we look at what's happening with the substance abuse crisis that's now confronting the white community, and we compare it to how it was dealt with in the black community back in the bad old days of the crack epidemic, we see white brothers and sisters have been medicalized in terms of their trauma and addiction. Black and brown people have been criminalized for their trauma and addiction. Michael Eric Dyson. We don't see images like this about white opioid addicts. We don't talk about super predators, and you think there's not the same level of family dysfunction and distress going on in these families confronting opioid addiction? But the national narrative is very different based on the color of the skin of the people affected. So last year, ProPublica and Consumer Reports, I love Consumer Reports, right? It tells me everything to buy. But they also told me in April of last year that car insurance companies charge higher rates in some minority neighborhoods. I put this slide in to remind us actually that almost everywhere we look, we will find discrimination. We find discrimination in housing, in banking, in employment, in education. All we have to do is look. So, if you live in a poor community, you have to pay more for your car insurance. And that's regardless, even when they control for crime rates. Even when they control for crime rates, people still have to pay more for their car insurance, just because of the color of the skin. So, Reuters has done some polling, and some of these are going to be a little hard for you to see, but I'll try to make the point quickly, looking at what's happening to race relations in America. So how much of a threat does racism and bigotry pose to the United States looking 2015 to 2017? What this is clearly about is pre-election and post-election, and what we see that there are many who believe that it is an imminent threat. More Democrats believe it's an imminent threat than Republicans. We continue to see just the enormous and growing divide between people in two parties in this country, which probably is not at all healthy for us. If we look at what is happening here. Okay, so I'll get something that's not making my slides move. Let's go back. Technology will kill you every time.
Use the arrow.
I'm going to. That's good. Okay. Here we go. Okay, I'm good. Don't worry. We got it. So, America is increasingly a place where I feel free to say what I think. Again, we have this sort of big divide between Democrats saying, no, not so much, and Republicans saying, yeah, it is increasingly a place where I feel free to say what I think. These days, I feel like a stranger in my own country. Again, big divide by party in terms of who is feeling ownership of this country at this time. We cannot disconnect this reality, if for no other reason than we have now entered into an age where we're saying, we don't have to pay so much attention to political correctness. I think of that political correctness as being civility, but hey, who knew? And so we continue now to have even more difficult conversations around race and racism. Out-of-touch kneeling NFL players are starting to ruin the emotional attachment to football. Because we turned these kneeling football players from a silent protest against black folks being killed by the police into something that got perverted to be about whether you're patriotic or not. It was never about that. It was always about those people whose names are on this slide. You know about Pikesville? I remind you of the images of Pikesville. I remind you of the words of Maya Angelou, who said that hate, it has caused a lot of problems in the world, but has not solved one. This picture made me totally have to rethink my notion of rednecks. Because now we got rednecks against racism. Like, right on, yes. Definitely, let's go there. We move to Charlottesville and we see images of torchbearers in Charlottesville. I heard a recent podcast from NPR reminding us that these are not all poor, young, unemployed white men. Some of these are very well-employed, middle-class, well-educated white men. These are images from Charlottesville. These are images from Charlottesville, and this is the woman who died in Charlottesville. We are in a difficult place. And Maya Angelou again reminds us that the plague of racism is insidious, entering into our minds as smoothly and quietly and invisibly as floating airborne microbes enter into our bodies to find lifelong purchase in our bloodstreams. Racism as an infectious disease. The metaphor could not be more powerful, and the problem is we haven't found a truly effective antibiotic. Just to keep my talk topical, just before I left home, this sign was put up in a post office in Flemington, New Jersey, because now that February is over, we have to celebrate March as National Stop Blaming White People Month. How does racism make us sick? There are study after study after study that shows us part of it is this linkage to toxic stress. Toxic stress is not a phenomenon that only affects children. It affects us all. There's internalized racism, institutionalized racism, and personally mediated racism. Personally mediated racism is well outlined in Unequal Treatment, the report from 2003 by the IOM that documented the things that we do in the healthcare system to treat patients unfairly. Institutionalized racism obviously has to do with the policies that adversely affect people of color in this country and do it with seeming abandon. And internalized racism obviously contributes to some of the behaviors that people of color engage in this country just to feel better, but that often result in adverse outcomes. I often wonder, what is the health impact of being racist? Can levels of hate really be good for your soul, for your body, for your mind? I suspect not. I believe that many of you understand that the moral arc of the universe is long, but it bends toward justice, that we cannot be full evolved human beings until we care about human rights and basic dignity, that all of our survival is tied to the survival of everyone, that our visions of technology and design and entertainment and creativity have to be married with visions of humanity, compassion, and justice, and we have to start using that language out loud. We have to regularly talk about our humanity, compassion, and justice, and that's why I'm speaking. Equality is not enough. We have to strive for equity, and we have to strive for equity in the context of reality. Because we don't have anything close to a level playing field. And I want to end by talking about Black Lives Matter. When we say save the rainforest, we don't mean that we cease to honor the mighty cedars or the reaching pines. We mean that one particular piece of a deeply sacred whole is more at risk than others, and that this risk, this threat, is worthy of our very bravest actions. So it is with Black lives in this country. And the message that Black Lives Matter is important so long as this nation effectively functions as if they do.